Hello, and welcome to the Med-SURG Nursing Journal podcast series. This series provides extended content relating to the articles published in the journal, such as author interviews and roundtable discussions. Before we get started, we have a special offer for our listeners. You can save 50% off 1- and 2-year subscriptions to Med-SURG Nursing, the official journal of the Academy of Medical Surgical Nurses. Simply visit medsurgnursing.net/offer to take advantage of this special discount. Acute-on-chronic pain and tolerance are very complex issues. The bedside nurse plays a critical role in pain management, including medication reconciliation and making sure home medications are continued in the hospital. Patient education is imperative. Managing the patient's expectation is key, but setting realistic goals is a must. Med-Surg Nursing routinely publishes articles on pain management. In this episode, Med-Surg Nursing editorial board member Susan Bohnenkamp cites 2 such articles recently published in the journal and talks with Dr. Heather Carlisle, a clinical associate professor at the University of Arizona College of Nursing. Dr. Carlisle is certified in pain management and palliative care and has published extensively on the topic of opioid safety and patient monitoring in acute care settings. Prior to joining the faculty, she worked as a nurse practitioner on an acute pain service at a Level 1 trauma center, where she consulted on patients with complex pain needs, particularly acute-on-chronic-pain. She coordinated the Pain Resource Nurse Group, a group of Med-Surg nurses who meet monthly to discuss their challenges with pain management and to share resources and expertise. We are pleased to present Susan Bohnenkamp's interview with Dr. Carlisle.
Hello, I'm Susie Bohnenkamp, a clinical nurse specialist at Banner University Medical Center in Tucson, Arizona, and I'm also on the editorial board for the Med-Surg Nursing Journal. I want to welcome everyone listening to the podcast on acute-on-chronic pain, the role of the Med-Surg nurse. In Cherie Rebar and Nicole Heimgartner's Quality Counts column titled Managing Persistent Pain Throughout Hospitalization, and this was in the July-August 2020 Med-Surg Nursing Journal, they discuss that while caring for patients with persistent pain, the medical surgical nurse should provide ongoing assessments and rely on evidence-based assessment tools. And this provides an objective way to determine the degree of pain present. Nurses are in the perfect position to advocate for patients who have untreated or undertreated persistent pain. In that same journal, Rachel French, Eileen Lake, Matthew McHugh, and Margot Brooks Carthen wrote an article titled A Systematic Review of Care Needs for Surgical Patients with Chronic Opioid Use. During this opioid crisis, hospitalized surgical patients that use chronic opioids have care needs that are not well understood. They did a systematic review that identified salient care needs and the role of nursing in meeting these needs. Results suggest pain management, patient assessment, and patient teaching are especially relevant. For pain management, sometimes they require larger doses and multimodal approach to obtain adequate postoperative pain management. Collaboration between team members is essential. Pain assessment, they have a higher risk of adverse events including infections and pulmonary complications, so they need more frequent assessments and monitoring. Patient teaching, it needs to be extensive, and it's about the unique needs to enhance the patient experience and optimize care delivery, and keep the pain management realistic. There was one more recent article about pain in the January-February Med-Surg Nursing Journal by Tyler Sturdivant, Christian Segan, and Azita Amiri titled Ethical Decision Making for Nurses Treating Acute Pain in Patients with Opioid Abuse History. In this article, they discussed how nurses have an ethical duty to treat pain in all patients. Some nurses struggle with treating acute pain in patients that have a history of opioid abuse. So today we would like to talk about some of the issues regarding acute-on-chronic pain and the role of the medical surgical nurse. It is my pleasure to welcome Heather Carlisle, who is a professor of nursing at the University of Arizona and an expert on pain management.
Thank you, Susie, for that warm introduction, and thank you to the Association of Medical Surgical Nurses for the kind invitation to speak with you about this important topic. And this podcast is really timely given the 2 articles about pain management in the current issue of Med-Surg Nursing that you mentioned. It also seems impossible not to see frequent news stories about the opioid epidemic in our communities. And I think nurses, particularly newer nurses, often feel uneasy about giving opioids. They want to help their patients manage their pain, but they also want to prevent the overuse of opioids. And so I think the challenge is even greater when patients already have a tolerance to opioids.
What do you mean by tolerance, and how would you define it?
So tolerance is when a person needs greater amounts of a medication in order to achieve the same results that they used to achieve on a lower dose. And this is actually a normal biological phenomenon. Tolerance does not mean that a person is dependent on the substance or that they're addicted to it. It just means their bodies have gotten used to a certain dose and it's no longer as effective as it was before. So they need, increasingly higher doses of the medication to get pain relief. And tolerance can occur with any kind of opiate, whether it's a prescription that someone is taking exactly as directed, or if they're taking their prescription medications not as directed, or if they're using illicit drugs like heroin. The physiological concept of tolerance is the same for all of those situations.
How can a nurse determine whether the patient is opioid tolerant?
So the bedside nurse really does play a critical role when the patient is first admitted to the hospital. It's really important to find out whether the patient has a chronic pain condition for which they take opiates regularly. And so they may take a long-acting opiate pill like OxyContin once or twice a day, or they might have extended release morphine, or they might wear a fentanyl patch. So it's important that the nurses and the provider are aware of that. I've seen patients with fentanyl patches where the nurse didn't realize they had a fentanyl patch on until the next day when they were doing a bath. So it's really important to make sure that you're not overlooking something like that, and then to make sure that the provider is aware. And this is where collaboration between the nurses and the providers is really important. Chronic pain medications should definitely be continued while the patients are hospitalized, unless there's a specific reason why they shouldn't, if there is a specific contraindication. And unfortunately, it's still pretty common for a provider in the hospital to stop those chronic pain medications when the patient gets admitted because they're afraid to have them be on opiates that they themselves didn't prescribe. And so the nurse really does need to advocate for the patient in those cases, because stopping chronic opioid medications may lead to withdrawal symptoms and will definitely make it harder to get the patient's acute pain under control if they're having surgery or something.
What if the patient says they have a substance abuse history?
Well, if a patient is an active opiate user, that really does complicate things. In that case, it's probably safe to assume that they have built up a tolerance to opioids. It really depends on how often they use it, when's the last time they used, and what medication it is. And there's really no way to continue their opioids as pre-hospital meds because we don't know the doses they were taking. We may not really know what drug it is because a lot of these pills on the street are cut with different things. And the person's probably using them inconsistently. And it's not like you can just look at your equivalent table, the equi-analgesic table, to do a conversion. So you can't, heroin's not on that table. So you can't convert heroin to a morphine equivalent dose and then give the patient the morphine equivalent dose to cover their baseline pain. So in these cases, there's going to be some trial and error to get the patient's acute pain under control. And so really the important things to recognize is that these patients who are substance users do have a tolerance, and they will likely require higher doses of medication to control their acute pain while they're in the hospital. And something I would really like to make sure is clear to everyone listening is that thinking about tolerance, it's not the same as med seeking. We sometimes talk about, well, that patient is med seeking. It's really easy to assume that a person with a substance use disorder is naturally going to be asking for higher doses of medication. And I think we often feel skeptical of patients at the bedside when they're telling us about their pain and telling us how much medication they need. But the thing to keep in mind that if a person has just had a trauma or just had surgery, of course they're going to have pain. And we have an ethical obligation to treat that pain. And treatment for the substance use disorder has to take a back seat during that acute phase of the illness or injury. And so if they have tolerance, they're going to need higher doses of medication to manage that pain. And we do need to manage that pain. And I know it's really important for nurses to keep in mind the longer term future for these patients and how to get them into treatment. But I've never met any patient who can make an informed decision about seeking addiction treatment while they're in the throes of acute pain in the hospital. So really getting that pain under control is the most important thing during this acute phase. And when we do that, that builds trust with the patient. And that trust may bring them one step closer to seeking addiction treatment later. You never know when that person is going to finally make that choice and finally succeed in that. And so building that trust is really important. Of course, all of this makes it hard to determine what is the optimal dose of the opiate for these patients. And that's where assessment and monitoring becomes extra important.
How can nurses know how much medication is safe to give patients who are opioid tolerant?
So careful pain assessment is very important, combined with a sort of step-by-step approach with medication. So we often say, start low and go slow. And that's the approach that you would take with someone who's not opioid tolerant, but also an approach that you would take with someone who is opioid tolerant. So with an opioid tolerant patient, when you're just not sure what they're going to need, you would start with the normal starting dose of whatever the medication is, just like you would with someone who does not have an opioid history. And then you reassess their pain after the appropriate time interval has passed and document the response. And so here's where the numerical pain scale is helpful, because if their pain goes from a 9 to a 5, then you know that that dose has been helpful. But in addition to monitoring for that pain response, that pain number, nurses also have to monitor for signs of sedation and respiratory depression. So if the patient is not showing any signs of sedation or respiratory depression. Sedation does usually come first before respiratory depression, but not always. Sometimes respiratory depression can occur quite suddenly. But if they are handling the medication well and they're not having any untoward symptoms, but they still have pain, then it is safe to give a higher dose. And so there's just a little bit of trial error that has to go on here. But as long as the nurse is monitoring that patient closely and the patient is not showing signs of having any dangerous effects, such as their breathing slows down, then you know that it is still safe to give them additional medication if they need it. And when this trial and error is going on, it's important for the nurses to communicate that at shift change so that everybody knows what we've tried, what was the result, and what seems to be the regimen that is working well for the patient. And I guess kind of an example of this trial and error and how challenging this can be, I had a patient one time a few years ago. She was a young woman in her early 20s with an active heroin use disorder. And she had started using heroin as a high school student in a wealthy area of town. And she was buying some heroin. She was participating in a drug deal. And there was a shooting that took place. And she ended up with a gunshot wound in her buttocks. And she was in excruciating pain. She was, somehow an ambulance was called and she was brought into the hospital. And this is when I was working on the acute pain service. So she had come in overnight and had a surgical procedure early in the morning, I think. And they consulted me because they weren't able to get her pain under control. And they were giving her, I believe they were giving her oral Percocet, which, was not nearly what she needed. Even I think if she hadn't been opioid tolerant, that would have not been a great regimen. Wouldn't have been realistic for that to control her pain, but they were really afraid to give her opiates because they knew that she had a heroin addiction. And so the approach that I took with her was to put her on a dilaudid PCA and allow her to push the button as often as she needed to push that button to get pain relief, not having any idea how high her tolerance might be given her recent heroin use. And it worked beautifully well. She pushed the button when she needed pain relief. She was closely monitored to make sure that she didn't push the button too many times and end up with her breathing slowed. There was a short lockout period between the button pushes on the PCA, but she pushed it when she needed it. And after 24 hours of her using that PCA, I was able to look at how much medication she had needed in that 24-hour period, and then convert her to an oral regimen with some IV for breakthrough. And we got her pain under control. She recovered really well, and she did, in fact, go into a substance abuse treatment when she was discharged. I think given how much she was suffering when I was first called to see her, I can't imagine that if we had not worked so hard to get on top of the pain, I don't know if she would have trusted us to the degree that she did. And we ended up having a really good outcome with her, even though it seems a little counterintuitive to give a heroin addict access to a dilaudid PCA and to let her push the button when she needed it. But the idea is you don't know how much they're going to need to get their pain under control. And so this was the approach that we took, and it worked well. And I guess there's one more opiate that I want to talk about, and then we can switch and talk about non-opioid medications. But questions often come up about methadone, because patients, they'll come into the hospital and they'll have methadone as one of their pre-hospital medications. And sometimes it's the case where the person is in an addiction treatment program where they go to a methadone clinic every day to get a once daily dose of methadone, and they have to present in person to that clinic to get that dose. But sometimes patients are on methadone, they're prescribed methadone for a chronic pain condition, because methadone is an excellent pain medication. So don't assume, when you see methadone on their medication list, don't assume that they're in some kind of an addiction treatment program. They may be getting this for chronic pain management. And in that case, it is especially important that they have that medication maintained while they're in the hospital, because it's very difficult to restart the methadone once they've been off it for a bit. It has a very long half-life, and I saw a patient once where they had forgotten to order his methadone when he was admitted, or maybe hadn't forgotten but didn't want to order it, because a lot of times physicians are reluctant to order opiates when someone gets admitted to the hospital. They just would rather just see what their acute pain is and medicate the acute pain. And so this man had not received his methadone for a couple of days, and he did in fact start to have withdrawal. And then the physician ordered it, realized, he was on methadone before, ordered it Q6 hours, which is very risky because it has a long half-life. It should not be given that frequently. And the patient ended up getting very sedated as the doses accumulated too quickly. So methadone is a tricky medication. And I would say the key message from this is if you do have a patient that's on that at home, find out why, is it for addiction maintenance or is it for chronic pain? And then make sure that it gets ordered for them while they're in the hospital. So far, we've been really focusing on opioids and opioid tolerance because those are the medications that often cause the most concern for nurses. But it would be helpful, I think, to talk about other kinds of medications that are commonly used for chronic pain.
What medications should nurses be aware of that are used for chronic pain?
Well, the standard of care for chronic pain treatment is to use a multimodal approach. And that simply means that we use combinations of non-opiate medications to attack the different kinds of physiologic pain mechanisms that are going on with a person in order to be opioid sparing. So remember that opioids are really only meant for acute pain. And my philosophy is that I will never start someone on an opioid without having an exit strategy in mind. So it's meant to be used for a short term to deal with an acute pain issue. And it may be a week or two. It's not like it's just going to be a one-time thing, but it's not meant to be months and months. So we try to avoid using opiates for chronic pain, except sometimes with chronic cancer pain, for example. It's important and necessary for patients with chronic cancer pain, bone pain, for example. Opioid medications are extraordinarily effective for that. But there are a lot of medications that are used for other conditions like seizure disorders or depression that also happen to work well for certain kinds of chronic pain. And so if a nurse sees any of these medications on a home medication list, this should alert the nurse to the fact that the patient has a chronic pain condition. And so medications like gabapentin, pregabalin, amitriptyline, nortriptyline, duloxetine are all medications that are commonly used for chronic pain conditions. And it's funny, sometimes patients don't even know why they're taking some of these medications. And I've had many times where I've been doing an admission history with a patient. And, I have to ask the usual things like, have you ever had a seizure? And they'll often say, I don't remember ever having a seizure, but I must have had one at some point because I'm on this medication called gabapentin. And when I Googled it, it says it's for seizures. So I guess I must have had one. And the same happens with antidepressants. Sometimes patients will say, my doctor has me on this and Google says that it's for depression, but I don't really remember that I was ever depressed. So when you see medications like that, don't assume that they're on it for a seizure disorder or for depression. They may actually be on those medications for chronic pain, or with the antidepressants, it may be that that medication is doing double duty because chronic pain and depression are frequently comorbid conditions. And so sometimes the provider will choose to use something like Cymbalta, which is duloxetine, to handle the chronic pain, but to also help with the depression. Really, the important thing for the nurse to know is that the patient does have a chronic pain condition, and therefore the medications should be continued while they're in the hospital unless there's a specific contraindication to a particular medication. And so the nurse can advocate and collaborate with the provider to make sure that those medications get ordered for the chronic pain.
How can nurses educate their patients about pain management in the hospital?
Well, I think the most important way to engage in education with patients is to have a dialogue with them about how to best manage their pain. So a lot of times patients, they've been in the hospital before, they know what works for them and doesn't work for them, and it is important to listen to that. With some caveats, sometimes patients have misunderstandings about allergies and things, and they think that they had an upset stomach with morphine, therefore they're allergic to it. And that's not a side effect, that's just a natural effect that happens with some of these medications, and there are ways we can mitigate that. So it's important to have a dialogue and at least kind of understand that person's pain history. We've really trained nurses to ask about a numerical pain score as the fifth vital sign, and we often sort of stop there. And I think we're doing a bit of a disservice to our nurses when we don't get more thorough about this, because the numerical pain score really only tells you about the intensity of the pain. It's useful, as I said before, as a measure of how effective the pain medication was. So if the score went from an 8 to a 4, that's good. But it doesn't really provide any clues about the type of pain or whether this is acute pain or chronic pain. So a patient may have chronic neuropathy in their feet that is always at a 5 every day, and they live with that. But they just had abdominal surgery, and so their acute pain in their abdomen is a 10 out of 10. So it's important to do a complete assessment because these types of pain can be managed quite differently.
How can a nurse manage expectations for the patient's pain? A lot of our patients want their pain to be a 0 out of 10.
Yeah, that's tough. And that is one of the things we ask patients is, we ask them, what is your pain on a scale of 0 to 10? And then what is your goal? What level, what number is tolerable for you? And when they say 0, well, then there's definitely a need for some education and to manage expectations. Because frankly, if somebody just had surgery or just had a car accident, they are going to have pain, regardless of what the surgeon may have promised. And there are still some surgeons who try to promise their patients that it's not going to hurt. And, that's not realistic. So we know that uncontrolled pain can lead to slower recovery time and complications like infections and pulmonary complications. But there needs to be a balance between pain control and functional ability. So I tell patients, we are going to do everything we can to keep you comfortable enough to do the things you need to do to go home. So getting to a pain score of 0 would probably require giving too much pain medication that would result in the person being too sedated. And if they're so sedated, they can't do the things they need to do to get better. They need to be awake and alert enough to do the activities that will prevent the complications and that will help them recover more quickly. So, for example, we always like our patients to use an incentive spirometer to prevent pneumonia. So if it hurts too much to breathe, then they're not going to be able to do that. They won't be able to breathe deeply enough to make that ball hover just in the right spot on the incentive spirometer. But if they're too sedated, they also aren't going to be able to do that. Similarly, they need to be able to move in the bed to prevent bed sores. We can come in and turn them every 2 hours, but it's a lot better if they can just make these small shifts when they need to shift their position and be more comfortable. So if they're having too much pain, they're just going to lie there rigid, afraid to move. But if they're too sedated, they're also just going to lie there not moving. They need to be comfortable enough, yet awake enough to ambulate in the hallway or to engage in physical therapy. So it's all really about finding that balance between the pain control and sedation and making sure that they're not having too much pain, but also not having too much sedation. And that really does take a conversation with patients so that they understand that there's a balance and we're going to work together with the patient to find the appropriate balance. And it may take a little bit of trial and error, but we're not going to let them be in terrible pain. We're definitely going to make them comfortable, but they can't expect to have zero pain. So I guess to sum this all up, we talked about tolerance and that tolerance can make pain management a little bit more complicated because we have to account for that when we're dosing the pain medication. And then we also need to monitor carefully to make sure that we're not overcompensating for the tolerance and then having them be overly sedated. We need to work with the patient to develop realistic goals for how to manage their pain and to make sure they understand that a pain score of 0 is probably not realistic, and that we want to focus on their ability to function comfortably. So, ambulating in the hallway for the first time when you've just had abdominal surgery, it probably is going to hurt a bit, and that's okay, but we're going to make it so that it doesn't hurt too much. But we're probably not going to have a pain score of 0, or they won't be able to actually hold on to the handles of the walker to ambulate. And then I think a critical role for nurses that often gets overlooked is that nurses are really the bridge between the patient's home medication situation and what's happening when they get admitted to the hospital. So it's really important to review the patient's home medication list to make sure that nothing got overlooked or left off that patient actually does need. Because a lot of times when someone is, particularly when they're critically ill and they first come in, the priority is always going to be on what are the medications that this patient needs right now at this moment. And so sometimes things like an antidepressant, aren't going to get ordered when they get admitted, but it really does need to be there if that's something that's helping with the chronic pain. So this is where I think the nurses have a critical role, particularly for advocating for that care for the patient and collaborating with the person that's writing the orders to make sure that those things get taken care of. I think that sums it up.
Thank you, Heather, for your time and all of your information on pain management. I can use this information right away in my practice. And I want to thank everyone for listening to our podcast.
The Med-Surg Nursing Journal podcast series is owned and produced by Genetic Publications Incorporated. All rights reserved. No portion of this podcast may be used without written permission. Dr. Heather Carlisle is a clinical associate professor and an AGA-CNP specialty coordinator at the University of Arizona College of Nursing in Tucson, Arizona. Ms. Susan Bohnenkamp is a clinical nurse specialist at Banner University Medical Center in Tucson, Arizona. For archived episodes of this podcast and to learn more about Med-Surg Nursing, visit the journal's website at medsurgnursing.net. You can also subscribe to the Med-Surg Nursing Journal podcast on Apple Podcasts, Google Podcasts, Spotify, Stitcher, TuneIn Radio, our hosting site, Spreaker, and everywhere podcasts are found. And remember, as a listener, you can save 50% off 1- and 2-year subscriptions to Med-Surg Nursing Journal. Simply visit medsurgnursing.net/offer to take advantage of this special discount.